Namaskar. You are watching Dr. KK Med Talks Fridays with Dr. Anita Kant, non-stop show 1022nd episode. Let's have the headlines of the day. About 15 to 20% of women will develop an ovarian cyst during their lifetime. For women over 45, the risk of an ovarian mass being cancerous is about 33%. A new study showed that 90% of postmenopausal women diagnosed with endometrial cancer reported vaginal bleeding before their diagnosis. Long term ultrasound testing may not be needed for older women with stable ovarian cysts. Artemisinin is known to be effective against malaria, lupus, cancer, and now possibly polycystic ovarian syndrome also. Let's go to the topic of the day. Today, we will be talking about ovarian cysts in postmenopausal women. And our special guest tonight is Dr. Narmada Hadikal. She is a distinguished gynecologist and fertility specialist based in Hyderabad and boasts of over 38 years of expertise. She is affiliated with premier hospitals in the city and has accumulated extensive overseas and rural healthcare experience. She has taught at esteemed institutions like Osmania Medical College and Gandhi Medical College, shaping the next generation of medical professionals. Serving as the medical director of Narmada Women Healthcare for 17 years, she is also a consultant at prominent hospitals including GVK EMRI, Geeta Hospital, and Rainbow Hospital. Her global contributions include advisory roles in Iran and research at Emory University, USA. So, Dr. Narmada, we are very happy to have you with us. We will be talking about ovarian cysts in menopausal women.
Okay,
Shall we
madam.
start?
Thank you. Good evening, all. And
Good
it's a
evening.
pleasure moment for me to be on this platform with you. Thank you. We'll proceed.
Okay. So, first of all, I would like to ask you what are these ovarian cysts and how do they form?
Yeah. Actually, most of the cysts are only normal cysts. Normal,
Mm-hmm.
like follicular and lutein cyst in normal women,
Mm-hmm.
like all women, they are very, very common. But
Mm-hmm.
when we are talking about the postmenopausal women, and
Mm-hmm.
because they don't have menstruation,
Mm-hmm.
because the release of the ovum will not be there, like every month. So
Mm-hmm.
in that case, even they will have some amount, some few cysts will be there. But I would like to call in postmenopausal women, it should be we should call it as masses, ovarian masses instead of cysts, because in reproductive age and also in adolescence and these women almost 17% of all the women in their reproductive and adolescent age, they produce some or other cysts, but they are functional. Coming to postmenopausal women, most of the times we always bother about if woman postmenopausal woman is having some mass in the ovary. Always we are concerned about that thing, and we should think the most of the times malignancy, because in postmenopausal almost in 18% of the postmenopausal women, these cysts are malignant only. So the problem here, and usually in reproductive age and also in adolescent age, people they usually visit doctor for pregnancy or for some menstrual problem and other things. The diagnosis will be early diagnosis will be there. But whereas in postmenopausal women, the problem is they menstruation will not be there, and moreover they will not the problem here, they will not show any signs and symptoms immediately. In these patients, usually like postmenopausal patients, if they are having any mass and the delayed response will be there, delayed symptoms and signs will be there. By the time we diagnose malignancy in those female, most of the times it may be inoperable and it may be in say stage 3 or 2. So that is the problem with the postmenopausal ovarian cysts and or masses.
So, what are the different types of ovarian cysts that can occur in a postmenopausal women, and any way to classify them or tell one apart from the other?
Yes. Uh, Actually, for these women, postmenopausal women, the malignancies are very, very common from 60 to 70 years of age. And most of the times after 45 years only.
Mhm.
As they don't have menstruation every month they will not secrete estrogen and progesterone, and but they will have epithelium on their ovarian surface. So epithelial tumors are common, and 80% of these malignancies are epithelial tumors, and rest are sex scar tumors, and also mesenchymal tumors, and also some these germ cell tumors. But these most of the times these postmenopausal women, they come with the epithelial malignancies, epithelial tumors, and out of these, by the time they come to hospital, the delay in the diagnosis will be there. The prognosis will be bad. And when we are talking about the cysts, cysts like retention cysts, those cysts are may be common, but not in delayed age. Not maybe not after 50 years of age. So whenever we see the mass in the pelvis in postmenopausal women, always think about the malignancy, and we have to act quickly. And the signs and symptoms are also very lately they occur. Like abdominal pain will be there, and they may think some maybe it is because of some urinary tract infection, lower abdominal pain, constipation will be there. Maybe they think because it is old age, they are suffering with the constipation, like that, and indigestion. And people may tell because the age is like that, and you are not able to have adequate food, like that, and loss of appetite will be there, but urinary frequencies will be there. At the time of that postmenopausal age, most of the people, almost 60% of the people, women, they will have diabetes. So when there is diabetes, naturally they have increased frequency of urine and also urinary tract infections. So all these club together, and abdominal swelling and fatigue. Naturally, everybody said because of the postmenopausal age, you are having fatigue. And these signs and symptoms are very, very common. And when and edema also. Uh, Unilateral or bilateral edema will be there, and abdominal distension. They present with the ascites, and all these signs and symptoms they present. But but the negligence at this age, the negligence will be there on each and every sign and symptom. But whenever patient present with like this, like any loss of weight, fatigue, and all these things, complete gynec examination is advisable for all postmenopausal women. And um, and we have to, of course, we take a pap smear every 3 years and do breast examination. Always concentrate on their breast palpation, and also gastrointestinal signs and symptoms are very, very common in these people, because of the because they present with most of the times it is maybe secondary to gastrointestinal tumors like colonic cancers and duodenal cancers and gastric cancers. Are these are secondary to those malignancies. So every woman and a postmenopausal woman, they have to undergo colonoscopy as well as gastroscopy and sometimes abdominal ultrasound. And even they develop a pleural effusion in unilateral and bilateral, and also most of the times right pleural effusion they develop. And in those cases, patient may present with cough and difficulty in breathing like dyspnea. In those patients, we should not neglect these signs and symptoms, and thorough examination should be done. And apart from all gynec examination, ultrasound examination, and if it is required, CT examination and MRI and gastroscopy, colonoscopy, we have to rule out. Apart from that, nowadays we have many markers, tumor markers are available. You want me to continue with tumor markers, madam?
Let's we'll be coming to them late sooner or
Yeah.
later. So, what are the primary hormonal changes in menopause women, and are they do they have any role in leading to the development of these ovarian cysts?
Yes, yes, exactly. That's a good question. Actually, the coming to the how the malignancies of the ovary will form, there are four schools of thought. The first one is, and ovarian is inassisted, and this inassisted ovum, that means every month egg will be released from the surface of the ovary, and what the epithelium will get ruptured, then that epithelium has to heal, so it will go inside the ovary, and the formation of the inclusion cyst will occur, and that is the cause, that may be the cause of the epithelial ovarian cancers. That is one school of thought. So whoever is undergoing every month menstruation, these chances are more. And second school of thought for the malignancies is and retrograde menstruation. So some potential oncogenic factors, they retrograde when patient is having menstruation, or also normal infections, and whatever it is from lower genital tract, it will go in through fallopian tubes, it will go into the pelvis, and these oncogenic factors may stimulate for the growth of the malignancies like epithelial tumors and other tumors. And also third one is because especially this applies to the postmenopausal women. Here in postmenopausal women, what will happen, because of the cessation of the hormones, and FSH will raise. FSH is bad for the FSH and LH is not bad, but FSH is bad for the this ovaries. And
Yeah.
also same applies to, and whoever is, whenever we are stimulating for infertility patients, we are stimulating ovary with medication and hormones, we are giving HMG injections and all these FSH injections. And with that also it will be stimulated. These all hormones also, and especially FSH is the maybe the cause for this malignancies of the ovary. And also fourth one is genetic. The genetic factor is very very important. Coming to when we have to discuss about this, this is the syndrome, ovarian breast carcinoma syndrome, and that will be there in some families, like that will run in families. Whoever is having that history of the breast cancer and ovarian cancer, and there are 50% of chances of developing malignant ovarian malignancies before 50 years of age. These things are very important. But other factors like using of the talcum powder on the perineum, and some pollution people, most of the people, whoever they are staying nearby some factories, and exposure to some kind of pollutions, and again the problem will be, and the stimulation will be more for the ovaries. And also third one, more fat intake in women, especially in western countries. And also these things, life pattern, of course, smoking, and cigarette smoking and alcoholic, of course they are there. And nullipara, whoever is not whoever, I mean, not having children and having a regular menstruation. And again, one protective factor is there, whoever are using this oral contraceptive pills, that is the best protective factor for these to develop these ovarian cancers. And also they have noticed one this thing, and whoever is having more children, and less chances of ovarian malignancies are there, because the 9 months they don't have ovulation, and other after that also they lactate the baby. So and a few more months they will not have. So anovulation is also is a blessing in disguise for these women. So these are the most of the times these are the risk factors.
So now the question of tumor markers has come from a viewer.
Yeah,
They are asking, okay, what are the tumor markers and what is the significance of CA125 in context
yeah,
to
yeah. Coming to
ovarian cyst?
we haven't discussed genetic this thing, and
Uh-huh.
one thing is that is BRCA 1 and 2. And if they find that BRCA1, and which is it is there on the 17th chromosome, short arm of the 17th chromosome. It's a genetic, and everybody can have this test. Uh, to know whether they are prone for this disease or not. Like BRCA1, whoever is having family history of BRCA1 is suppose mother or first degree relative they got, and if they undergo the BRCA, if it is the gene is present, they may get 50% of malignancy that this thing. And also BRCA2 and the chromosome, again short arm of the chromosome, it will present on the 13th chromosome. These two genes are in future it may be helpful for all women whoever is having the family history or exposure to such kind of things. So these two things, and in BRCA2, and the chances of getting these malignancy is less compared to BRCA1, and only 13% of the people with BRCA2 positive, they may get these epithelial malignancies, and some other genes are there, but not at completely confirmed by doing that. And coming to the tumor markers, here coming this uh, first first and foremost, but whenever we see this ovarian mass or cyst, always we do CA120 levels, but this shows only in epithelial ovarian cancer, it may be positive. So there are so many other tumor markers like in mucinous cystoenoma, carcinoembryonic antigen may be present, and also in endometrioid sinus tumors, and alpha fetoprotein may be present. All these tumor factors. In the embryonic cell cancer, HCG may be present, and also endometrioid tumor also it may be present, and also alpha fetoprotein. So all these HCG, the lactase dehydrogenase 1 and lactase dehydrogenase 2, and also inhibin in granular cells inhibin, and this is another tumor marker. So these, if patient, and we suspect some these mass or cyst in women, and always we have to think about all these things apart from the scanning and other things. Markers should be done, not for every case, and when we doubt about malignancy in the ovary.
So, what are the current treatment options available in for a menopausal woman with a cyst? When to operate, what to give, and how
Yeah.
do you decide on the best course of action?
Yeah, and first, of course, we have to work up completely, like basic blood workup, and almost always better to search for the primary thing. That the problem is here, whether it is because for every malignancy, secondary may be the ovarian malignancy. So, as we discussed, in 30% of cases, if patient developed primary malignancy is the breast, and 30% of those breast cancers, and this woman may develop ovarian cancer in 30% of cases. So always we have to focus on the primary malignancy, and whether it is arising from the colon, because non-polyp cancers of the colon and very common in women, and that secondaries may occur in ovary, and also not only colon, duodenum, pancreas, and gastric masses, and all these secondaries can occur. But the thing is here, we always try to differentiate between the primary and secondary. If it is primary, that treatment is different. If it is secondary, the treatment is different. If it is secondary, we have to treat the primary cause. Like a gastroenterologist has to see he has to do, colonoscopy and take biopsy and other things. First, rule out whether it is primary or secondary ovarian malignancy. Of course, if it is primary ovarian mass, and we do all these genetic tests, and we prepare, and most of the times the we can do diagnostic laparoscopy to know whether the after doing all CTs, MRIs, and other scans and other tests, and X-ray test to rule out pleural effusion, and cardiac monitoring, everything has to be done, and better to take small biopsy if it is possible, through diagnostic laparoscopy, and we can see the environment, surroundings like uterus, and ovaries, fallopian tubes, and also pelvis and other things, whether there is any amount of fluid is there in the pelvis, and those things we can see. And if we feel that there is and by inspection, the morphology of the ovary is also we can visualize, because in morphology, and the secondary, most of these secondary tumors are like Krukenberg tumors. Yeah, they are bald and waxy type. And if we take the biopsy, signet ring appearance will be there. Like and they are very big, but of course they are not much malignancy. But inside they will not spread the entire abdomen. But these ovarian tumors, usually the spreading of the ovarian tumor is also we have to discuss here, and the peritoneal spread will be there, surface spread will be there. And once ovarian cancer occurs, the spread it will spread directly in the abdomen everywhere. So it will through gutters and paracolic gutters and pelvis and below diaphragm, everywhere it can spread easily. So second spread is of course lymphatic spread. Lymphatic spread most of the times, because the ovarian, this is only para-aortic nodes. The spread will be most of the times para, and sometimes superior gastric nodes, because the connection is there to the gastric, this thing lymphatic spread, connection is there to the stomach. And hematogenous, of course it is that, but always because it is a systemic supply, not portal supply. Immediately it will not go, secondaries will not go into the liver. If patient is having ovarian malignancy, it will not go into the liver. And firstly it will, in first stage, first or second stage, it will spread through the hematogenous spread in systemic circulation. And coming to the staging of the, and we can we are just by inspection we can stage, and what kind of and whether it is stage 1, stage 2, 3 are inoperable, like that. Based on that we can plan the treatment. And we can take and instead of taking frozen biopsy, we have to take direct cytological biopsy. When we put laparoscopy, we can aspirate fluid from the gutters and from the pelvis to send it to the pathologist, and they will diagnose. Or else we can take small piece from the ovary and send it, and there itself we can inspect all other organs, and like ovary and other ovary. Mostly 70, almost 50 to 70% of the ovarian tumors are bilateral, and especially if they are secondary to some other malignancy, 70% or 100%, they are, most of the times they are bilateral ovaries will be affected. So that is the problem. So if and when we put laparoscope, if both ovaries are having some different, I mean differentiation, if you can make out, and better to take small biopsies and take aspiration and look other things, and come out, and then you can plan for the based on the stage of the surgery and the type of the tumor, like whether it is sex card, epithelial, because epithelial tumors are, the prognosis is very bad compared to other tumors, like in a dysgerminomas and teratomas, the prognosis is good. And in menopausal women also, these dysgerminos, dysgerminos and teratomas can occur. But in when coming to the epithelial tumors, their prognosis is bad. So and after doing this, and once we diagnose it, and next we have to plan laparotomy. um, and in laparotomy also, debulking of the ovary based on the stage of the thing, and hysterectomy. We may plan for hysterectomy, bilateral salpingo-oophorectomy, and palpation of the para-aortic lymph nodes and other things, and send it for biopsy, and after that plan for chemotherapy, or based on the stage of the tumor, radiotherapy. And nowadays we have very good medicines in chemotherapy, in chemo, and good radiation techniques also available.
Right. Very well said. Now, a viewer is wanting to know ki in what circumstances is surgery considered for our ovarian cyst in this age group. Like, is it the size or something else that prompts you to go for surgery?
Yeah, staging, madam, and we have based on the stage and size also. And when we because we do we did not do laparoscopy, and we palpated, we did pelvic examination. Okay, and we found some masses are there, and posterior vaginal nodules are there, and uterus is fixed. In CT scan or MRI scan, we found that it is inoperable, in inoperable stage. But still, we have to do debulking. Debulking means we have to take out the whatever the structures, and like both ovaries, tubes, and uterus up to cervix. And apart from that, omentum, parts of the omentum. Most of the times, better to take more pieces and more biopsies from in different parts of the omentum, because the omental spread will be more. And not only that, and mm, uh, like the fluid, ascitic fluid, we have to take for cytological tests. Based on this, we have to plan the surgery. And but whatever it is, laparotomy is mandatory for these cases. And in these cases, even second look surgery also we can do. First we have done we removed, and we have given all other medication like chemo and all, and the second look surgery, and whether it is whether we have removed it completely or not, that also we can plan. But in some rare tumors like in sarcomas and rare lipoid tumors, the prognosis in postmenopausal is very very bad, especially sarcomas. And in those cases, I think we cannot do this as second look surgeries and all, and directly we can go for chemotherapy or radiotherapy based on the these oncosurgeon or these medical oncologists, whatever they advise. Like,
So, in case a woman lets it doesn't look to be malignant on a CT scan or MRI or even ultrasound, and she doesn't get operated, what are the complications that can arise from this untreated ovarian cyst?
yeah, complicated untreated ovarian cyst. Better to do diagnostic lab and do some biopsy. And if uh, still we leave it, and the size may become more, and urinary complications, because it may press on the bladder, and frequent urinary complications will come, constipation, because they press on the rectum, and ascites, they may develop ascites and pleural effusion if it is malignant. The spread will be very fast in these cases. Complication, and stage 1, it may spread from stage 1 to stage 2, like that. The prognosis is very fast in ovarian like epithelial ovarian tumors. That is the reason whenever we see some cyst or uh, my experience and opinion, whenever we see some mass in postmenopausal women, it has to be treated completely in and out. We should not neglect, because a patient may not come for follow up sometimes based on their other conditions. So, and thorough treatment will be there, should be there, like removal of the mass, and also hysterectomy with the bilateral salpingo-oophorectomy, and take omental biopsies and other things, and send it for all biopsies, and cytological examination of the fluid in the peritoneum. Peritoneal fluid has to be sent, and palpate all other nodes, and whether they are if it is palpable, and better to take biopsy from them.
So, another viewer has asked, can some lifestyle changes or particular dietary recommendations can be taken to reduce the size of the cyst or not have cyst at all?
So, madam, in postmenopausal women, actually, of course, dietary changes and lifestyle management, I don't think it will work on them. Because for polycystic ovary cysts and some other cysts, we can advise lifestyle changes and these dietary changes. For these people, always we should tell and better to take care of their. They should take high protein diet, and if they are diabetic or having some hypertension, naturally they have to take a low salt diet. Low salt diet and low sugar diet. They have to control other other medical problems, and also they should regularly go for pap smear test and on pelvic examination. Every year they should come for at least once in a year. They should undergo ultrasonography, and so sometimes sonomammography or mammography if some mass is there in their both breasts. These things are very very important. And some and x-ray lung or X-ray also we should take, and colonoscopy they have to undergo compulsory. And also if they're having any indigestion or anything, they have to undergo gastroscopy also. These things they have to compulsory. The screening test should be done for all these women when whoever is having small cyst or doubtful family history of these masses. Mm, and it should be it can be controlled by all these things.
So, can hormone replacement therapy or any hormonal treatment influence the development of ovarian cyst?
And actually, these hormonal, normally, and in reproductive age and pubertal age, these will work. But most of the times, not in menopausal age group, ovarian cyst or malignancies. And in these, perimenopausal age, we can, if they are having some functionalities, we can give oral contraceptive, cyclical oral contraceptive pills, or at least progesterone we can give in perimenopausal. Because if they're presenting with the abnormal uterine bleeding, in those cases we can try hormones. And also in reproductive age and also in adolescent age, prepubertal age, if they are having follicular cyst or corpus luteum cyst, we can try cyclical hormone therapy. They will work. But in postmenopausal women, the hormones itself won't be there, and we cannot try with the estrogen hormone, HRT, and we cannot try these hormones on postmenopausal women. But whereas in pubertal and also in reproductive age and perimenopausal age, we can try hormones, cyclical hormone or continuous hormone. And this by giving these hormones, the size of the cyst may be reduced, and also we can maintain the anovulation, and further the shrinkage and reduction of the size of the cyst may be there.
Right. So, any takeaway message, take home message for our viewers today?
Yes. And actually, all women, in my opinion, and all women should undergo regular breast examination palpations, and they should go undergo almost at least once in 3 years sonomammogram, and that means ultrasonography of the breast they should undergo. And if their strong family history is there, they can even have mammogram. And also if they are having any palpable mass, they can have mammogram. Apart from that, and pap smear is mandatory for all women once in 3 years when they enter into the actual sexual life. And all women they have to undergo this pap smear test, and speculum examination, one pelvic examination. And that is pelvic examination, this is mandatory. By doing pelvic examination we will come to know many things. Unless nowadays people most of the times they are only depending upon the scannings, but when we do pelvic examination, we can palpate masses in the posterior fornix and right and left fornix, and size of the uterus very clearly, the firmness and other things we will come to know. And if at all any like ovarian mass, other things also we can, whether they are mobile immobile, we can differentiate, of course. And apart from that, and it is mandatory to take cervical cancer vaccination in all women. And also better And better, people can use oral contraceptive pills, cyclical oral contraceptives for spacing of the children, and these pills are preventing so many malignancies. So that is advisable. Hormonal contraceptive pills are advisable. And spacing of the children is also very, very important. Apart from that, ultrasonography once in at least 3 years. Most of the times, our women and in our culture, once they have children after tubectomy, they will not see doctor at all unless until they have some problem. So it should be mandatory to visit a gynecologist at least once in 2 years for ultrasonogram to know the size of the uterus and ovarian size, endometrial thickness. All these things are very, very important, and also nutrition is very important, like and prevention of the anemia and in menopause always the calcium and vitamin D3 is very less, and that supplementation should be there, and HRT, and unnecessarily nobody should use HRT unless until gynecologist advises. So nowadays it has become like once the periods cessation occurs, and they over the counter also people are taking HRT medication, and that should be taken only after pap smear and examination of the breast in the presence of the gynecologist. If they prescribe, they have to take. And when they are taking HRT medication, they have to be under control. They have to see the gynecologist once in 6 months for the pap smear and other things. These are my
Treatment.
suggestions.
Yes.
Thank you.
Thank you. Thank you so much, Dr. Narmada, for joining us today. Could you please show us the certificate, please?
Yeah, thank you. Thank you.
This is a small
And
token of thanks from us.
I'll download it. Thank you, madam. Nice. Yeah.
Thank you. Thank you so much. That will be all for today. Dr. KK Med Talks will return tomorrow at 7 p.m. with another edition of the show. Keep watching Dr. KK Med Talks. Namaskar.